I'll be talking briefly about orbital tumors. Orbital tumors are a very wide spectrum and it's impossible to cover most of the tumors within 30 minutes. But I would show you a logical approach that is required for a postgraduate student and a practitioner. When you have a patient with orbital tumor sitting in front of you, you ask yourself certain questions. What is the tumor likely to be? Is it a benign tumor or a malignant tumor? Or it's not a tumor, is it a pseudotumor? Inflammation am I dealing with? Where is it located in the orbit? Anterior orbit, posterior orbit? Is it related to any of the extraocular muscles or the optic nerve? Is it operable at all by me, or do I need a neurosurgeon holding my hand? What approach would I undertake? Do I do it by the conjunctival approach? Would I need a lid crease approach or whatever? And what to expect at the end of it? Do I expect to just get an incisional biopsy, or would I want to do an excisional biopsy? What complications would I expect and counsel the patient for? A stepwise approach would start with a very good clinical history, not just a routine ophthalmic history but relevant systemic history as well, depending on the situation. Regional examination would include not just the eye but the entire face, regional lymph nodes and the rest of the body as appropriate. Systemic examination is part of proptosis workup. Imaging, MRI and CT scan, the discrimination, or just do an ultrasound B scan depends on your clinical suspicion based on the first three steps. Specific investigations would follow, and then surgery, and finally histopathology, and guided by histopathology you would necessarily give adjuvant therapy where indicated. If you were to go by stepwise approach in this child who was born with right eye proptosis, what do you expect in this child? Looking at the child, what is the possibility? A child born with proptosis, what are the three major causes for a child being born with proptosis? And you can also take a clue from the left eye. It is little triangulated. The cornea is not really round. It is little triangulated. If the cornea is triangulated, the pupil is expected to be colobomatous. So if a patient has coloboma in one eye, what is it likely to have in the other eye? Yes, that is a microphthalmus with colobomatous cyst. Because it is located in the inferior orbit, the diagnosis is quite appropriate as a clinical diagnosis. And all you need to do here is aspirate the cyst and prognosticate vision in that eye. Sometimes, surprisingly, these eyes tend to have little larger corneas than what you see here, 6-7 millimeter corneas with reasonably well developed retina and may have even reasonable vision, finger counting or even vision good enough for mobility. So once you prognosticate that the vision is not going to be there, then you can do sclerotherapy or excise the cyst and give prosthesis. If vision is likely to be there, and of course you have to manage the cyst conservatively, and not do alcohol injection, or if you want to do sclerotherapy, it has to be something that won't cause much of inflammation. Another situation where a child is born with proptosis. What is the possibility here? Here the eyeball is well formed as you see here, but then behind the eye there is what looks like a cystic lesion which is growing by the day. The child was born with this, by the next day it was little larger, and the third day it was much larger. What are the possibilities? A growing teratoma, right? Teratoma which is very rapidly growing, and if it develops periocular hemorrhage and also has bone deficiency, then it's more likely to be a malignant teratoma, and that would need immediate attention. You have dermoids that are around the orbit. Internal angular dermoid and external angular dermoid are very easy to excise by the lid crease approach. But when a dermoid has restricted mobility, if the dermoid cannot move full range either vertically or horizontally, then you have to suspect that the dermoid may have a extraorbital extension. As you see here, this is a dumbbell dermoid. Part of it is extraorbital. There's a bone defect here. So you have to plan your surgery very carefully, make osteotomies on either side of the dermoid and remove the entire lesion en bloc without rupturing the lesion. Otherwise, if you leave any part of the dermoid behind, it might lead to recurrence or fistula. One more similar example where dermoid looks very small. It's very innocuous looking, but then it has restricted mobility, which prompted us to do a 3D reconstruction of a CT scan, and you can see a defect in the orbit there, and that is the extraorbital component. If I were to just remove this, then this would recur maybe with a fistula. So you have to be very careful in dermoids with restricted mobility. And this is an anteriorly located lymphangioma, preseptal lymphangioma, which can be debulked. But lymphangioma generally can be diffuse like this. Diffuse lymphangiomas can also have a localized component, may have acute exacerbation during URI, and also can form chocolate cysts with massive proptosis appearing suddenly. And a limited lymphangioma excision or debulking can be performed in an appropriate situation. Now, if you have an elderly individual with enophthalmos but complains of occasional proptosis. What is the possibility? Specifically, if you see something which is little dilated on the conjunctiva, orbital varices. So what test would you do in orbital varices? Valsalva maneuver is mandatory in orbital varices, and also ask the patient to bend down, stay in that position for 2 minutes, and then examine the patient as the patient is bending down. Actually, you have to position yourself in such a way that you examine and then document the amount of increase in proptosis when the patient is bending down. These are indications for management. Patient has to either change his or her lifestyle if there is increase in proptosis during bending, or you will have to use embolization of the connecting vessels. If you have a patient who has mild to moderate axial proptosis is very disproportionate to the size of the tumor that the patient has, and the tumor is very well circumscribed and it is intraconal. What are the possibilities? Cavernous hemangioma is a very good possibility. Intraconal, well circumscribed tumor with axial proptosis, and the proptosis is disproportionately less to the size of the tumor because the tumor has been lying around for a long time. It has caused orbital fat atrophy and also expansion of the bone. As you see here, there is concavity of the bone on the involved side as compared to the contralateral side. So the tumor has got itself accommodated in the orbit, that thus resulting in less of proptosis as compared to the size of the tumor. Chronicity, benign tumor, and it's a cavernous hemangioma. Another possibility is neurolemoma. Neurofibroma of the orbit, even melanoma, circumscribed melanomas are known, and benign fibrous histiocytoma. These are common differential diagnoses for a well circumscribed tumor in the intraconal space or even extraconal space. These are readily excised without much complications. These are the so-called laddu tumors which are ready to pop out the moment you make your incision, delight to any orbital surgeon. Now, if you have a similar situation, proptosis, but then in cavernous hemangioma, ocular motility is never restricted. It may be restricted in very huge tumor because of mechanical issues, but otherwise because of muscle infiltration it's never restricted. Here is a situation which looks like cavernous hemangioma, but then the patient has restricted ocular motility, and also there is some kind of a cavitation effect within the lesion, and the periphery of the lesion is grossly enhancing. You must think of hemangiopericytoma, which has about 30 to 45% chance of being malignant and needs to be completely excised, followed by adjuvant therapy such as stereotactic radiation. We have a child here who looks like orbital cellulitis, right? Upfront you would diagnose this as orbital cellulitis. But in chemosis, in orbital cellulitis, has to be passive chemosis. It won't be fiery red, fleshy chemosis like this. Chemosis in orbital cellulitis can be pitting. You apply a cotton tip applicator and press it for a few seconds and you'll find a pitting there, and that will resolve over time. But this is solid chemosis. A solid chemosis with ocular motility restriction in a child would tip you in favor of rhabdomyosarcoma. But solid chemosis of this sort is very characteristic of what is the diagnosis? Angiosarcoma. Angiosarcoma of the orbit can be exactly like this with solid chemosis. That's the only differential diagnosis I know for solid chemosis in a child with rapidly evolving proptosis. Now this is an example of a patient who has an extraconal well circumscribed lesion. Extraconal well circumscribed lesion generally present with displacement of the eye, specifically if they are present anterior to the equator. But even otherwise, massive lesions like this can cause displacement of the eye and also excavation of the bone. So well circumscribed extraconal lesion more likely to be a neurolemoma, specifically if it is if the internal consistency of the lesion is isodense. If it is variegated, then it is more likely to be a cavernous hemangioma. Even neurolemoma can be completely excised without any complications. Intraconal lesion in a child with proptosis, axial proptosis, most likely to be neurofibroma or optic nerve glioma. Optic nerve glioma is more possible in a child who is of this age group, specifically if the child has stigmata of NF1. It can be unilateral or bilateral and can not be necessarily restricted to the orbit but can extend intracranially, as you see in this situation. Now this lady comes to the cataract surgeon for cataract surgery. Obviously she has bilateral cataract, not very severe though, but she also has relative afferent pupillary defect. So what are the possibilities? She has mild proptosis, very mild proptosis. She has RAPD, and this is what you see in the fundus. What are these vessels called? Optociliary shunt vessels, and little bit of pallor which looks like secondary optic atrophy and folds at the posterior pole, and when you do imaging in this patient, you will find that the optic nerve is grossly thickened. It can be irregularly thickened as you see here, or it could be like a straight thickening of the optic nerve with calcification of the optic nerve sheath. That's called tram track calcification, which is very characteristic of optic nerve sheath meningioma. We have a younger individual here which also looks like optic nerve sheath meningioma. She also had RAPD, but accompanying that she has thickening of the extraocular muscles. So this is not meningioma but diffuse non-specific orbital inflammation with myositis and perineuritis components. So when you look at the CT scan, the diagnosis generally becomes quite obvious. And if a patient were to have a lesion centered in the sphenoid vein causing extension into the orbit, intracranial space and also temporal aspect centered in the sphenoid vein with hyperostosis, then what is the possibility? And swelling in the temporal fossa. Sphenoid vein meningioma. So this is called a triradiate lesion. There are many examples for a triradiate lesion, one of which is sphenoid vein meningioma. Ewing sarcoma in a young individual can also be triradiate. Even for that matter, eosinophilic granuloma is triradiate. Metastasis, many of the metastases are triradiate. Triradiate almost always has equal proportion of distribution centered in the sphenoid vein with equal components in the orbit, intracranial space as well as in the temporal fossa. I'll show you some examples later. Now what if a child comes to you, a 5 or 6 year old child comes to you with acutely evolving proptosis, very vascular, located in the inferior orbit or maybe superior orbit? What is the possibility? What is the first test that you would do in this patient? Not radiology, but peripheral blood smear is absolutely necessary because chloroma can mimic this, but otherwise it could be rhabdomyosarcoma. The first test that you do is not incisional biopsy or a CT scan, but a peripheral blood smear to rule out chloromas or leukemias, and then you go in for further investigation and then do an incisional biopsy to establish the diagnosis of rhabdomyosarcoma. It can also occur in the superior fornix. The botryoid variant of rhabdomyosarcoma specifically occurs in the superior fornix, and when you do imaging MRI here, you can see that there is anterior orbital extension as well. This is a triradiate lesion again in a retinoblastoma survivor. When he has reached about 20 years age, he has developed this. What is the possibility? Osteosarcoma is the definite possibility because it is a second malignant neoplasm in a retinoblastoma survivor. So what about this? Bilateral proptosis, diffuse preseptal mass and also moth-eaten appearance of the extraocular muscle. Xanthogranuloma with a yellowish hue that you can't miss. Even in a pigmented individual, you can't miss the yellowish hue. Xanthogranuloma with, of course, systemic overlay has to be ruled out, adult onset asthma and other immunological disorders. Now, lacrimal gland lesions can be cystic. This is a cystic lacrimal gland lesion located in the orbital lobe and also has a palpebral lobe component. More likely to be a, what is the possibility? Dacryops. Dacryops of the palpebral lobe is very common, but dacryops can also occur in the orbital lobe present as a cystic mass. And a more dense lesion, despite this bony defect here, well circumscribed lesion is more likely to be a lacrimal gland lesion, more likely to be a pleomorphic adenoma of the lacrimal gland, which can be easily excised. But if it were to cross the midline, any lacrimal gland lesion, if it were to cross the midline, as you see here, then most likely it is malignant. Either it is an adenocarcinoma, as in this patient, or adenoid cystic carcinoma despite the age. This is a teenager, but still the lesion has crossed the midline. You would see on CT scan that the lesion has definitely crossed the midline. The patient had pain, which is unusual in pleomorphic adenoma. She obviously has a lesion which is malignant since it has crossed the midline, and she turned out to have adenoid cystic carcinoma. Metastatic lesions again can be triradiate, can happen in the bone as in prostate, can also happen in the extraocular muscles or in the soft tissue of the orbit. This is bilateral breast metastasis. In these patients, despite a orbital mass, the patients will have inophthalmos. Why is that? Yeah, these are desmoplastic. These can sclerose, and that is the reason why they cause fibrosis in the orbital fat, resulting in inophthalmos despite the presence of an orbital mass. And this is a muscle metastasis from a melanoma. Now, children can also have metastasis. If you have bilateral proptosis in a child with a temporal fossa swelling, you won't do anything else except send this patient to a pediatric oncologist on the same day. What is this? Neuroblastoma or dephroblastoma. This is metastatic Wilms. Exactly similar situation with periocular hemorrhage. The diagnosis is neuroblastoma. Just one differential diagnosis, nothing else. And Again, a triradiate lesion, very characteristic of metastatic neuroblastoma. A lesion that molds around the eye in an adult. Very nice rounded contour, molding around the eye, painless lesion, chronic, indolent. Lymphoma, lymphoproliferative lesion, most likely to be lymphoma. Now, if you have a child like this with acute proptosis with subconjunctival hemorrhage, what is the test that you would do? And also pale-centered hemorrhages in the retina. Peripheral blood smear again. She turned out to have a granulocytic sarcoma. So when you talk about surgery in the orbit, first come injection. Patients of this sort with capillary hemangioma of infancy with orbital extension, primarily a lid lesion, but this child has a lot of orbital component as well, resulting in hypoglobus. You can give intralesional, one single injection of intralesional triamcinolone is good enough to resolve the condition over about 3 months of age. But then if you are a little conservative, you can start these patients currently on oral propranolol, 2 mg per kg body weight for prolonged period. But then if you have a very high risk of amblyopia as in this child, it is best to give one single injection of intralesional triamcinolone in the dose that is specified, 6 mg per kg body weight. And then whatever that is residual, you can slowly control with oral propranolol, not resort to further intervention. In eosinophilic granuloma, when you suspect a osteolytic lesion in the orbit and you suspect eosinophilic granuloma, of course you have to do an incisional biopsy to confirm the diagnosis, but you hold the child under anesthesia and get an intraoperative diagnosis from the pathologist. And the pathologist, once he confirms it is eosinophilic granuloma, all you need to do is intralesional steroid injection. Here again we give triamcinolone in the dose of 6 mg per kg body weight, and over a period of 6 months you can see that the bone actually remodels, resolving the lesion. So these patients don't need extensive curettage, damage to the dura and intervention by a neurosurgeon or systemic therapy. All they need is a single injection of intralesional steroid. Of course you investigate them for systemic lesions as well. In patients like Ewing sarcoma, where you know for sure that you cannot excise the lesion completely and you only want a diagnosis, you would resort to incisional biopsy. Once the diagnosis is confirmed, these patients can be treated with chemotherapy and radiation. Same with NHL, B-cell lymphoma or any sort of lymphoma where all you need to do is incisional biopsy, not try to remove the lesion completely. Same with sphenoid wing meningioma. But irrespective of what is the diagnosis, if a tumor were to be well circumscribed like this, away from the extraocular muscles, away from the optic nerve, where you are not likely to cause any sort of complication to the patient, you cannot think of incisional biopsy. You have to excise this tumor, because this is unlikely to cause any functional problem at the time of surgery. Any well circumscribed lesion, there is no space for incisional biopsy in your protocol of management. It has to be excised irrespective of what it may turn out to be on histopathology. Same with neurolemoma. And once you have thought of surgery, there are several approaches. Neurosurgical approach is favored in patients who have a brain overlay. If you have a, say, optic nerve sheath meningioma where you want to excise it completely, or optic nerve glioma where you want complete excision, then you have a neurosurgeon coming in hand. Endonasal approach is possible in patients where there is primarily a paranasal sinus pathology. Otherwise, it is all orbital approach. Like this patient with optic nerve glioma, transfrontal approach is favored if you want complete excision. For this patient with allergic fungal sinusitis, transnasal approach is favored. When you talk about orbitotomy, there are several approaches, one of which is anterior orbitotomy. You may want to remember these names. Transcaruncular incision goes by the name of Balk and Goldberg. If you simply remember Goldberg, that would be enough. Inferior fornical approach. Inferior fornical approach with lateral canthotomy, a very panoramic exposure of the orbit, goes by the name of McCord-Moses. And inferior fornical with transcaruncular doesn't go by any name, but it is also a very useful approach for orbital fractures. Transcaruncular approach can be effectively used for intraconal lesions which are located on the medial aspect. You can see that a cavernous hemangioma has been removed in this teenager. Similarly, a teratoma in this child has been approached with inferior fornical approach. A large teratoma, you can see a tooth within it. That is the gross specimen, and that is the postoperative result. All we did here was a fornical approach with a small lateral cut. That will give you good exposure to the entire inferior orbit and also the intraconal space. In anterior orbitotomy, you might also want to remember the names. Upper lid crease incision goes by the name of Harris. Subrow incision goes by the name of Benedict, B for Benedict. Lower lid crease incision goes by the name of Davis. Lynch incision is this, which is used by ENT surgeons in the supranasal aspect. And the vertical lid split incision goes by the name of Byron Smith. Anterior orbitotomy lid crease is generally for dermoids and lacrimal gland tumors. Lymphangioma of this sort or anything which is located in the supranasal aspect can be removed with a vertical lid split incision. This is a video that shows the vertical lid split incision, where you actually create a iatrogenic lid laceration, very controlled vertical lid laceration. That will give you adequate exposure to the medial orbit. You can go right to the extraconal space and progressively into the intraconal space if you wish. And you land on the anterior surface of the tumor. Once you've seen the tumor, you don't use any forceps to hold the tumor, but dissect it with blunt applicators, blunt instruments. And anteroposterior traction is applied with a cryoprobe. Everything else is under visualization without cutting anything except fibrous septa, that too under visualization. As you apply anteroposterior traction, undress rest of the tissues very carefully, making sure what you are cutting, that's a fibrous band that is being cut. Otherwise, if it's an extraocular muscle, you gently coax out the adhesion, not cut anything in the orbit. And especially when the tumor comes out finally, you must look for vascular pedicle that has to be cauterized. Otherwise, there might be postoperative bleeding. And closure is very simple by a marginal suture, as you would close a lid laceration, and rest of these sutures put in place would make a very gratifying cosmetic outcome as well, without the scar being seen after about 6 weeks. Now, lateral orbital approaches, there are several approaches. Most favored currently is lid crease approach, but stellarterite incision, not as acute as this, but a lazy stellarterite incision of this sort is also used for a good approach. This is a stellarterite incision for lateral orbitotomy. You can see the incision is being marked. This is a little older video, shows more acute S. Currently we use a more lazy S. Skin incision. You can use radiofrequency or carbon dioxide laser right at this stage. Subcutaneous dissection is by RF. Lift up the tissue and dissect so that you see the plane. Change in color indicates change in plane. Everything under visualization with minimal bleeding. If you expect a vascular lesion, then you can ask your anesthetist to give hypotensive anesthesia. Periosteal dissection. Periosteal incision 4 mm from the arcus marginalis to the extent that you desire. And at the end of periosteal incision, you give a relaxing incision towards the orbit. Similar periosteal incision on the lateral aspect. Relaxing incision. Periosteal dissection. Initially using a sharp tip periosteal dissector and then a blunt lens spatula. Specifically where the suture is, you have to be careful not to rip the periosteum. Temporalis dissection. Temporalis fascia is dissected under visualization. This is in preparation for a bone cut for lateral orbitotomy. Bone cut is done only when indicated, when space is inadequate. Otherwise, you don't generally do a bone cut. Superior edge of the bone cut should correspond to frontozygomatic suture. Inferior, you can go as low as you want over the zygoma. There are no crucial structures there. And use a saw, which could be an oscillating saw or a sagittal saw. This is an oscillating saw. 70,000 RPM, so you have to be really under control of the situation. Spatula guards the structures of the orbit, and this is under constant irrigation and suction. Bone is cut at both the edges, and then it is out fractured or valgus fractured and preserved for replacement. You don't need to drill holes through the bone to replace. You simply have to use a drop of cyanoacrylate glue and the bone goes into position finally at the end of surgery. Periosteal incision is in the form of T. The horizontal limb of the T runs parallel to arcus marginalis and the vertical limb of the T runs towards the orbital apex. Once you've given the periosteal incision, the tumor starts prolapsing. That's just the anterior part of the tumor. And use blunt dissectors, not holding the tumor but holding adjacent inarcuous structures to dissect the tumor. Once about 50 to 70% of the tumor dissection is complete, apply the cryoprobe for anteroposterior traction. And as you visualize the rest of the structures, each of which is separated under visualization without damaging any of them. You would have tagged the lateral rectus and the superior rectus if a tumor were to be located in this situation, because then you can actually pull on the muscles and then look if they're adherent to the tumor and then separately dissect them, each of them. And the wound is closed after replacement of the bone. That was lateral orbitotomy, and it can be used effectively for tumors, much larger tumors as you see here, which are located in the intraconal space. Wherever they are in the intraconal space, specifically if they are lateral to the optic nerve, this is a good incision. If the tumor is medial to the optic nerve, then you don't want to use this incision and instead use an inferior orbital approach or a medial orbital approach. Much larger orbital tumors can be removed by this approach. Even optic nerve glioma, where excision is indicated, can be approached by a deep lateral orbitotomy by the lateral approach. Now for tumors which have involved the orbit and also the conjunctiva and the eyelids, you have to resort to orbital exentration. And when you do orbital exentration, you preserve enough skin. Despite this being a case of sebaceous gland carcinoma, diffuse sebaceous gland carcinoma, by using frozen section, you can be sure that the margins are all clear and all this additional skin that is there can be used to provide a horizontal blepharophy, so that the patient gets a nice concave flap of skin over the exentrated orbit on which a exentration prosthesis can be fitted. The procedure of exentration is a little changed now. This is how we do it. We mark the area to be excised, use sutures to close the palpebral fissure, and then use a RF to make the skin incision. Then directly go to the orbital rim by using retractors. The rim is exposed and 4 mm of periosteum over the rim is exposed. That is where you would mark the incision. Inferiorly, a similar dissection is carried out. Periosteal incision 4 mm from the orbital margin all around. Then you progressively cut all the structures, starting with the contents of the superior supraorbital notch, then the trochlea is disinserted, then come medially and then disinsert the medial canthal tendon. Laterally, the frontozygomatic suture, zygomaticofacial and the zygomaticotemporal nerves, and medially dissect the sac, expose the nasolacrimal duct from both the sides, superiorly as well as inferiorly, and then cut the NLD. That's the NLD being cut. Once you cut the NLD, you expose the posterior ethmoidal artery, cauterize it and cut the contents of the inferior orbital fissure and the superior orbital fissure. Superior orbital fissure structures have to be cut blindly because they cannot be visualized. And then you are ready for exentration or removal of the entire contents of the orbit. Use a blunt tip tenotomy scissors to progressively cut the contents of the orbit. Anyway, that video is skipped. Now this is how you rehabilitate the patient, either a spectacle mounted prosthesis or a glued on prosthesis. Now with orbital exentration, we used to have very high mortality with 50 to 75% death in many patients who had orbital extension of intraocular, eyelid or conjunctival tumors. So we use multimodal therapy in these patients. Like this patient with retinoblastoma with orbital extension, you give chemotherapy first, reduce the orbital component completely, make the eye thiazical, then go ahead with enucleation with the results of this sort: cosmesis preserved and life sustained. Secondary orbital retinoblastoma, where it has recurred following enucleation, you do the similar protocol with cosmesis preserved. Similar protocol is applied for rhabdomyosarcoma, where we begin with chemotherapy, provide stereotactic radiotherapy as a sandwich manner between three clusters of chemotherapy, and then further chemotherapy with preservation of vision. So is the situation with adenoid cystic carcinoma. You can see this child 5 years ago would have had no hope. This tumor has extended even to the cavernous sinus. But following completion of treatment, her bone has completely got remodeled. This is possible in children with the tumor completely gone, and the child is doing well. One more patient where there was cavernous sinus extension, a recent patient, inoperable otherwise, with chemotherapy and stereotactic radiation, the tumor is completely gone. These kind of magical results can be expected with multimodal therapy. One more patient with adenoid cystic carcinoma of the lacrimal gland, bone completely remodeled following complete treatment. Sebaceous gland carcinoma, where earlier used to do orbital exentration, can be now managed initially with chemoreduction. You can see after chemoreduction, all the tumor that is left is so much which can be completely excised. For tumors earlier where we would do orbital exentration like OSSN with orbital extension, we can currently manage with limited excision and plaque brachytherapy. So for melanoma. So that's where I would conclude. Thank you so much.